Mr. Chairman, I'd like to ask Ms. Fisher and Mr. Todd if they have any data or analysis that would give us any indication of how a value-based model might affect rural providers. That's something is of great concern to us. If there's any distributional impact analysis, because obviously this is something that those of us who represent a lot of the rural hospitals and rural providers are very concerned about as we move forward.
Senator Thune, thank you for the question. In terms of explicit distributional analysis, we don't. What we could say is that a rural physician, really any physician, but a rural physician would be better in the VBP program than where they are in current law today. And I don't just mean in a repeal of the SGR, though certainly getting rid of that uncertainty is helpful. Under current law, you have penalties for the value-based modifier, the electronic health record, and the physician quality reporting program that total in current law minus 7%. The challenge is they're in different parts of the statute and physicians aren't aware of them. But what we've done is collapse these programs into one program. That's an overall quality program that, one, will be easier for them to understand, will reduce some of the administrative burdens on them, but also in the beginning part, the payment implication is capped at 4%, whereas in current law it's 7%. So we actually think it's pretty good for all physicians, but that's also good for rural docs.
Go ahead.
Well, I would just say I might add, in consideration of that, it's part of the reason in the clinical improvement activities that the MARC says, let's look and talk to physicians and see where they are and see what they're capable of doing and pushing and challenging them forward to do. I should also point out that in the Chairman's MARC, there's an inclusion of the ability of physicians in small practices to group together to become a virtual group so that their data are looked at together. We heard a lot about that for rural physicians in Maryland under Care First, who by themselves, their numbers, because they may have a patient who is an outlier, the quality scores, the resource use scores may not be really reflective of their practices. This allows them to come together and perform better under the system. And we also, the Chairman's MARC also includes additional funds for technical assistance to help physicians in rural areas and small practices. But I would also say, Senator, that I think Dan has taken meetings, and I certainly have taken meetings from a number of practices in rural areas in Montana and talked to physicians who are providing very high quality, constrained resource care coordination for their patients, who believe and that we believe will do very well under this program.
One of the components, a significant component, I think it's 25% of a value-based payment, however, is EHR meaningful use, and that's something that in rural areas probably not going to get there as quickly, obviously, as you might in other areas. So any thoughts about how you address that?
Well, Senator, one of the things about the MARC's concept here in the value-based program is that it is budget neutral, and so the weights and the construct of what that funding is, to the extent that it doesn't work, and we believe it will, and we're hopeful it will. But if it doesn't, it's very easy for Congress to go back because it's not going to cost anything to redirect.
Thanks. Thanks, Mr. Chairman.